or extra, I should say, necessarily different. Anything extra? No? Okay. All right. Well, let's go ahead. Number two.
Number two, although the cardiac output.
Yeah, Nicole is now.
Oh, I'm sorry. Go ahead.
Although the cardiac output from the left and right ventricles are about the same, the cardiac work index of the left and right ventricle is not. Explain the reasoning for this in detail. Although the left and right ventricles eject the same volume of blood, the work performed by the left ventricle is much greater since it must eject against the mean aortic and mean aortic pressure, which is 6 times greater than the mean pulmonary artery pressure.
Okay. Is it mean airway pressure?
Mean artery pressure, sorry.
Oh, okay. Yes.
Yeah.
Okay, where'd you find that?
On page 355.
Okay, all right. And then, AJ, where'd you find yours?
That was on page 355 as well.
Okay. All right, next.
Okay, then explain why the ventricle stroke work is, its ventricle stroke work is a measure of a myocardial work per contraction. It's the product of the SBI times the pressure across the vascular bed. I found that on page 355.
All right, next.
Explain in details why the RVSWI would be greater than normal for a patient with pulmonary hypertension. SBI is the measure of myocardial work per contraction, high blood pressure that affects the arteries, and the right side of the heart failure is pulmonary hypertension. RVSWI measure the amount of work required by the right ventricle to pump blood. I got this one in card page 356.
All right, okay. All right, number 5.
Identify the 3 factors that determine the stroke volume. And as preload, afterload, and contractibility, and that's on page 354.
Okay. All right. 6.
Identify the 2 factors that determine the cardiac output. I have heart rate and stroke volume on card 354.
Okay. All right. Next.
Number 7, define preload. Explain Starling's law and how it relates to preload. Preload is the strength on the ventricular muscle fibers before contraction. Starling's law is the greater the stretch on the resting ventricle, the greater the strength of contraction within physiological limits. When the physiological limits are exceeded, greater stretching of the muscles does not result in a increased force of a contraction. And I found that on page 357.
Okay. Anybody have anything extra or add to that? Everybody had the exact same stuff? Okay. All righty. Long break.
Under normal conditions, the heart is able to push forward all the blood that returns to it. What branch of the autonomic nervous system allows this ability? Sympathetic nervous system, page 354.
Yes.
Number 9. Normally, about 2/3 of our total blood volume resides within the venous blood system. Calculate the percentage of blood stored within the venous system at rest. So for this one, I got it on Part 355. I got 20% to 25% of the total blood volume can be lost without altering circulatory function and pressures.
Okay, so then how much is stored in the venous system?
How much stored in the venous system?
Mm-hmm.
2/3. Or I guess it would be 1/3.
If you go to page, if you're on page, where is that? 354. It mentions 2/3. 2/3 of the blood is your total blood volume is in the venous system. So that calculates out to be about 60-ish%. So if you just kind of make note of that, and that's at rest.
So 64% is what you're looking for?
In the 60s, yes.
Okay.
Can you say that's at rest?
Correct.
Okay.
Okay, next.
Explain how, in addition to acting as a reservoir of blood, the venous system provides tissue regulatory control of the cardiac output. The venous system acts as a reservoir. The concentration of carbon dioxide, oxygen, hydrogen ions, electrolytes, and other humoral substances regulate capillary blood flow. And that's on page 354.
Okay.
Define ejection. Its more value, 2 ways it can be obtained specifically. Ejection fraction, the percentage of the EDV is in the that is ejected with each heartbeat. Normal value is 65% to 70%, and your ejection fraction is measured directly or calculated from the following formula: is your ejection fraction equals your SV divided by EDV. That's 356.
Okay. All right. And if you go to 356, be careful with the ejection fraction because, tell me again, Flo, how can you measure it? How is it measured?
It is measured directly or calculated from the following formula, which is your EF equals SV divided by EDV.
Well, that's one of them, and then you can move that around. Also, you can use, if you look on page 355, don't get that confused with that chart there, the Dubois body surface nomogram, right? Okay, because what do we use the BSA nomogram for?
To measure BSA.
For what purpose?
For your cardiac index.
Cardiac index, stroke volume index, and then also from your last side. Oh, goodness.
What is that noise?
Somebody's gonna need to mute their computer there, and also to get the dosages for your children and adults. So you can use that nomogram for those values, not to do the ejection fraction. Right? Just be careful with that. Huh? All right, let's go to 12.
Explain in details why the pulmonary capillary bed pressure would be increased above the normal level in a patient with left ventricular failure What is the most common cause for a reduced pulmonary capillary bed pressure? Identify 3 names for bed pressure. PCWP would be increased above the normal level in a patient with a left ventricular failure because the lack of forward flow out of the left ventricle causes the left ventricle to dilate and blood to back up into the pulmonary circulation. Hypovolemia, pulmonary capillary, the 3 names: pulmonary capillary wedge pressure, pulmonary artery occlusion pressure, and pulmonary capillary wedge pressure. That's on page 345.
Yes, correct. Questions on that one?
No.
All right.
13, during PPV, the positive pleural pressure can cause inaccurate PCWP readings. Identify the peak level limit that tends to have effect on the intrapleural pressure. I have 20 centimeters peak, and I found that on part 347.
20 is
Yeah, I have 20.
all right. 347. I've got 10.
Yeah, I have less than 10.
Yeah, less than 10.
Last night I seen 10.
All right, okay, so 10. What we're going to make sure that we make note of. Now, where'd you get 20 from?
I think I have 347 on my paper. But when I was reading last night, I did see 10, so I don't know if I just wrote it down wrong, if I was thinking something different. When I read it last night, I seen 10.
Mallory, you're gonna have to mute your. All right, okay. They have double values on here, so I wanted to double check. They had 20 somewhere. We'll look at it, but okay. All right, that was what, 13?
Mm-hmm. Yeah.
14.
That's Mallory.
Are we on 14?
Yep.
Identify what is the most important factor in the assessment of the cardiovascular system's ability to meet the body's metabolical demands. I have adequacy of perfusion on 348.
Say your answer again.
Adequacy of perfusion.
All right. Everybody have that?
Yeah.
All right, let's move on.
All right. Number 15. Does inadequate blood flow to the tissues result from low blood pressure? B, does a normal blood pressure always indicate optimal blood flow to the tissues? And C, why or why not? All right. So for A, blood flow to the tissues can be inadequate when blood pressure is low, but normal blood pressure does not mean optimal blood flow to the tissues. Can be caused, and it can be caused by poor venous return or circulation on page 355.
Yes. All right. Everybody get that?
Yes.
Yes.
All right, and that's in your simply stated box here. Okay. All right, next.
Number 16, what individual variables affect cardiac output? Age, gender, body size, hematocrit, and tissue demand for oxygen. Page 354, box 16.1.
Okay. Okey doke.
17, identify the common situations patients in with PAC monitoring is considered. Got cardiogenic or septic shock, major thoracic surgery, severe ARDS who are hemodynamically unstable, severe cardiogenic pulmonary edema. That is on page 354.
Okay, would that include the use to monitor a pulmonary embolus?
No, this is monitoring of patients who have major thoracic surgery or diagnosis and the treatment of patients in cardiogenic or septic shock. So I don't.
Wouldn't you have to do a X-ray for that? A special X-ray?
What do you mean?
To find.
You can do a special X-ray, but I mean, as far as catheter is concerned, would you use your PAC to monitor a pulmonary embolus? And I think Flo just said no. So if you're looking at the bottom of page 341, it mentions all of the situations in which PAC is considered, and it mentions, ARDS or cardiogenic pulmonary edema, septic shock, etc. Patients who are hemodynamically unstable. But for the pulmonary embolus, you're going to use the CVP catheter. So it's more appropriate to use your CVP catheter. So no to the pulmonary embolism for PAC. So yes, you would use special imaging if you're going in to go get it. If you're looking to see where it is and then you're going in to go get it, you're going to surgically try to remove it. Yes, you need special imaging for that. Okay. All right, next.
The tip of the pulmonary aortic catheter has a small inflatable balloon. Identify the two reasons for the balloon. The balloon is used both to float the catheter into position and to obtain wedge pressure measurement.
And you got that from where?
I got that from page 342.
All right. Okay. Next.
Okay. Identify the locations of PAC balloon inflated and its purpose for inflation. I got the right atrium, the right ventricle, pulmonary artery, and it's float the balloon through the pulmonary artery and to measure the pulmonary capillary wedge pressure.
Okay, so question, because you mentioned a lot of different locations. So what were those for? The question said identify for PAC, the locations for PAC balloon inflation. So are you saying that
it's floating through those?
Floating through it, okay.
Yeah.
All right, good, okay. And initially it's inflated where?
Initially it's inflated in the pulmonary artery. Oh, initially it's as soon as they put it in, they inflate it in the right atrium so that it can float over to the pulmonary artery.
Right. Okay. All right. Very good. Okay. Next.
Identify conditions that would result in an increase in PAP. Identify how to measure right ventricular failure. PAP increases in increased venous return, increased intrathoracic pressure, increased PVR. How to measure right ventricular failure, preload and end diastolic filling pressure, ability of the right side of the heart to move blood through the lungs and the left side of the heart in page 341.
Okay. All right. So question. How would you measure right ventricular failure?
I'm not sure. Is that the right one? Preload and end diastolic filling pressure. Is that the one?
I'm sorry?
Preload and end diastolic filling pressure.
What about it? No, I'm asking how. How would you measure right ventricular failure? Which one of those pressures would you measure right ventricular failure with? Would you use PCWP? Would you use your PAP? Would you use your CVP? Which one of those would you use? Because your PAP you would use for your pulmonary embolism, mitral valve stenosis, hypoxia. But what would you use for right ventricular failure?
Is CVP?
Say it like you mean it. Yes, CVP. Yes, CVP. Correct. All right. Okay. All right. Next.
Define CVP. Identify what it represents. When is CVP monitoring indicated? Identify the insertion sites and its most stable insertion site after placement. The pressure of the blood in the right atrium or the vena cava. And then I have the end diastolic pressure in the right ventricle, and it reflects the right ventricular preload. Assess the circulating blood volume, adequacy of venous return or right ventricular function. Subclavian and the internar jugular veins, and the subclavian vein is the most stable insertion site, and that was found on part 337.
Okay, everybody get that?
Yeah.
So the catheter site that's most used after placement and accurate hemodynamic information for that CVP catheter would be which one? Because you mentioned two. So which one of the two is the most stable vein?
The subclavian.
The subclavian, yeah. Okay. Great. Tell me again, what does CVP represent?
The pressure of the blood in the right atrium or the vena cava.
Okay, all right. So you guys, did y'all have more on that? Because there are other things that you can mention about what it represents. So yes, it does. It represents the pressure of the blood in the right atrium. What else?
I have reflects pressure changes in right atrium because the tricuspid valve is open between the right atrium and ventricle during diastole. CVP is also represents the end diastolic pressure in the right ventricle and reflects right ventricular preload. Yes,
yeah.
To assess the circulating blood volume and adequacy of venous return or return ventricular function.
Okay. All right. Okay. Yeah. So make sure you have all of that. All right. So CVP, yes, it does represent the pressure in the right atrium, but it also represents right ventricular preload, right ventricular end diastolic pressure as well. All right. And that's on 337 too. 337. All right. Next.
I think it's supposed to be Mallory. Do you want me just to go ahead and go?
Please.
Okay. All right. Number 22, identify the advantages and disadvantages of the insertion site for a CVP catheter. Advantage, more stable after placement, and then the disadvantage is the vein is harder to find and guide wire does not follow the vein exactly. And I found that on page 337.
Okay. All right. And also, I don't know if you mentioned this, tubing is not stable, less likely to kink in a patient who is awake. So that's not an advantage. All right, next.
Identify some primary causes for CVP to increase and to decrease. Increase volume overload, increase intrathoracic pressure, cardiac tamponade, pulmonary hypertension. decreased vasodilation, hypovolemia, spontaneous inspiration, placement of transducer above the patient's right atrium, page 340, box 15.3.
Okay. All right. Anybody have anything extra?
I just put a couple down because it's the entire box. I didn't know if we should write the entire box.
Well, it's up to you whether you write it or not, but gotta know it. But one of the primary causes to for that CVP to increase, make sure you know that a mechanical does cause it to increase. So there are a lot of causes, but definitely since you're monitoring a ventilator, you should know that CVP can increase because of mechanical ventilation. All right. Okay. All right.
24.
Next. Actually, in your notes, you should, even if you don't write it down, where you should, make note of the different ones, but still note where to find it, find that answer for when you go back to study. So
Yes.
it's always good to make note of it. All right. All right, let's go on. That was what, 22?
That was 23.
24.
So 24, identify indications for arterial cannulation.
AJ, you're muted.
Oh, shit. Thank you. 24, identify indications for arterial cannulation / arterial monitoring. I got diagnosis and treatment of patients with severe ARDS who are hemodynamically unstable, monitoring of patients who have had major thoracic surgery, and diagnosis and treatment of patients in cardiogenic or septic shock. 341.
Yes. Who has some other stuff? There's some more information. What else?
For arterial cannulation, it's used to determine the cardiac output, evaluate intracardiac shunts, and valve dysfunction, diagnosing pulmonary hypertension, essential component in the evaluation of patients before the heart and or lung transplantation. And that was 341.
What page?
341.
Oh, okay.
Yeah.
What you said, that's the arterial monitoring, and then what I read is the arterial cannulation.
Okay. Thank you.
You're welcome.
Questions. Did you say that arterial cannulation is indicated to determine cardiac output?
It says used to determine cardiac output.
Where
Or
did
no,
you?
cardiac output. That's a,
Huh?
it's not cardiac output. It's
Where did you see that? Where did you?
I don't think it's that. I think it's CO. That may be
Well, CO is cardiac output, so that is correct.
That's what it says. 341.
You're at on 340. Are you in the?
It's in the paragraph that says
Yeah.
for pulmonary artery pressure monitoring, and then it's like 1, 2, 3, 4, 7, 8. 9. It's like the 10th line down. It starts with however it can provide direct hemodynamic data that can be used to determine cardiac output as well as evaluate intercardiac shunts and valve dysfunction.
Okay. All right. So now that's just saying what it can be used to do, but that's not the indication for it. Okay. So be careful with that. So cardiac output. So from page 332 and 333, it talks about the indication for it. So you're talking about patients who are unstable. So when you've got a patient who you're having to continuously, if they're coding quite a bit, cardiac, they're going in for cardiac surgery, things like that, severe hypotension, unstable respiratory failure. Let's see, where is that? 333, and I think it goes over to 332, and then it goes over to 333, talking about the indications for it. So hypertension, patients with significant hemodynamic instability, hypotension, hypertension, receiving medications that affect blood pressure. They have your vasodilators or your inotropic agents, or requiring frequent arterial blood sampling. There's your unstable respiratory failure. May benefit from the placement of an arterial catheter and continuous pressure monitoring. So those are the indications for it. So once you have it in, now what can you do? You can do those other things like get cardiac output, but you wouldn't insert the catheter just to determine cardiac output. Like if I, like right now, for me, if you want to determine my cardiac output, you wouldn't need to do such an invasive procedure to determine it, right? You wouldn't do that. So you would use other methods, non-invasive methods, to get my cardiac output and get like an estimate. But for those folks who are really unstable, then yes, you would go that invasive route, because the catheterization is very invasive. So you wouldn't do that on a lot of folks because that would cause problems for them that are not necessary. So just remember, severe hypotension, unstable respiratory failure, and then also if you're trying to avoid multiple injury from those multiple punctures, those are the indications for arterial cannulation. Okay?
Okay.
Alrighty. All right, so that was 24. All right, let's go to 25.
Identify the sites where arterial catheters can be placed. Identify the preferred site and why. The insertion site for it is the same as the CVP, with the subclavian route being most common site in the ICU.
Okay, well,
And
now this is a little different. This question is asking a little different. So this is asking just arterial catheter. The question would be like either your radial, your femoral, your brachial, so axillary, those types of areas. Where would you insert an arterial catheter? So that's just for like an A line. So the arterial catheterization is your A line. The other catheters, you're talking about your subclavian or your jugular vein there. So you're talking different insertions there. So on page 333, when you're talking about just the arterial, so remember for your A lines, you've got different catheters. So for your A-line catheter, you're going to need to go to an artery. So the same arteries that you would stick to get a blood gas would be the arteries that you would go for when you're inserting that A-line. So for this particular question here, for arterial catheterization, when it asks that question, what's the most common site for arterial catheterization? You're talking the
radial, the ulnar, and the brachial.
Right.
And the axillary.
Right. So those your sites there that you would go to. Of all of those, the radial is your most common.
Okay.
Mm-hmm. Yeah, because we go radial, femoral, brachial. You mentioned ulnar. There's actually multiple sites. You guys went over some sites in 210 that you can where you can get a pulse and also stick for a blood gas. So that's the same thing if you need to, if you had to. I've on RT go between your toes, and I've never done that, but you can. There's a nice little artery right there that if you can't get any of those other ones, there's one, a nice pulsing when you're in between the toes. Never found that, but it exists. Question?
They would use ulnar as well, even though that's to the hand. So is the ulnar like one of the last resorts?
What do you mean?
So like we don't usually use ulnar for ABG sticks just because it's that extra blood flow to the hand in case something happens to the radial. So putting an A line in the ulnar wouldn't that cause issues?
Well, you can do a blood gas from the ulnar. The radial is the easier stick because of the direction of the blood flow. So you can get a blood gas. It's not an easy spot. I've seen doctors go for that ulnar artery many times. You know, when patients have difficult sticks, it's just not your first line of choice. I've never seen the A line put there because of, again, the blood flow and the direction of blood flow. But I mean, if you had to, but I've never seen anybody who needed the ulnar and they couldn't get the femoral. So if you had to, if you had issues with your radial, issues with your brachial, then the femoral is your definitely your go-to. And usually you can get the femoral artery. It's such a huge artery. So I've never seen anybody having to do that, but it's an option. You have multiple areas where you can, but those are the most common ones. So the ulnar definitely would be next in line. If for some reason you had a patient that had injury to the groin and you couldn't get the femoral, and that would be an issue, then yeah, go for that ulnar. You might have trouble with the blood, just because of the direction of the blood flow in the hand. Because when we're doing our sticks, we're talking about blood entering the hand and then blood returning from the hand. So you would have to, of course, if you go for the ulnar, you'd have to go in the opposite direction because of the blood flow. So you just have to remember that when you're sticking, but you can get it. Yep. Okay. All right.
Okay.
All right,
26.
Okay. 26.
Flow. Yes, yeah.
What is it that the cardiac knot, and what does it represent on an arterial pressure waveform? An arterial pressure waveform should have a clear upstroke on the left with a cardiac knot representing aortic valve closure on the downstroke to the right.
Okay.
And then 334.
Yes. Question to you. Now, if I said that the dichrotic notch represented pulmonic valve closure, would I be wrong?
Yeah.
Or aortic valve closure.
Maybe not. All right, so somebody said yes. All right, what about the rest of you? Would I be wrong if I said it represents pulmonic valve closure?
I say yes, you'd be wrong.
Okay.
Yeah. Say yes.
All right, tell me why. Why would that be wrong?
Because it represents
Because it
aortic.
represents the aortic
You can't
valve.
use that as your description as to why. Tell me why. Wrong. So tell me, why does it represent aortic? Tell me that. Why does it represent aortic valve closure, since you're stuck on that? So tell me that.
Because it says that's the meaning of it.
Come on, y'all. Put sticky caps on.
Is it because it has a secondary rise in the descending part of the arterial pressure waveform that corresponds to the
Are you saying
aortic valve?
Are you saying yes or no to it? I don't know.
Okay, because one you're talking about the pulmonic valve closure. That's on the right side of the heart, and the other one is on the left side of the heart. That's how I'm kind of thinking. So I don't think so.
Okay.
To do it?
Okay. All right. So now let's go back to blood flow. Okay. So remember when we did blood flow, you had blood that was, let's start on the right side, right? It's coming through that right atrium, going through which valve to get to the right ventricle?
Tricuspid.
Okay. Go down to that right ventricle. Then where does it go?
Through the pulmonary valve.
Goes to the pulmonic valve, right? Mm-hmm. And then it goes on to the trunk, onto the lungs, right? Then when it comes back, your blood re-enters the heart via on the left side of the heart via the pulmonary veins, goes into that left atrium, goes through which valves?
Bicuspid.
Your bicuspid, right, or your mitral valve, right? Same thing. Goes down to the left ventricle, and it swings around, right? Blood is pumped upwards and through the aortic valve to the aorta to the body, right?
Mhm.
All right, so now when the heart contracts, right, you've got the atrium, your two atria that contract at the same time, do they not?
Yes.
Yes, the atria contract at the same time, so that means your
The valve.
bicuspid valve and your mitral valve both open and shut at the same time.
Mhm.
Correct? Right?
Yes.
All right, so coming back around, now you have your pulmonic valve here going this way and your aortic valve going that way. Do they not open and close at the same time?
Yes.
Yes.
They do. So would I be wrong if I said, well, that diacritic notch also represents the pulmonic valve closure?
No, that wouldn't be wrong.
Yeah, I don't think it would be wrong.
Yeah, I mean, in most of your books, it mentions the aortic valve. I don't know why they're more partial to the aortic valve, but I've always learned it was a pulmonic valve. So I see in different books that it says pulmonic valve. Some books say aortic, but they both open and shut at the same time. So when you're getting that reading on the pressure waveform, you're seeing the result of both of them opening and closing, and of course the diacritic notch is created when it closes. So aortic valve closure is certainly not wrong. It's in your book that way, but just note that you are going to see pulmonic valve closure as well in other books, because that's correct too. They both open and shut at the same time. Okay.
Thank you.
Thanks for the analogy.
Yeah.
Thank you.
Sure. That's just something that I always see that. I was like, well, okay, well, make up y'all minds. But I noticed they don't always see that the book, and I never got clarification on it, but the books never say both. It doesn't mention both. It'll just say one or the other. But so you're not confused when you do see one of your articles or a book that mentions pulmonic valve closure. It's talking about the same time if you're looking at timing as the aortic valve. Okay. All right. So let's go on to 27.
What is the pulse pressure? Why is it significant hemodynamically speaking? The pulse pressure is the difference between the systolic and the diastolic pressure. Normal pulse pressure is 30 to 40 millimeters of mercury and is a reflection of a left ventricular stroke volume and arterial system compliance. A pulse pressure lower than 30 millimeters of mercury indicates low left ventricular stroke volume. If the pulse pressure increases with the fluid therapy, the patient was probably hypovolemic. That was on page 336.
Okay, very nice. Okay, so make sure you take note of all those things that the pulse pressure represents. Pulse pressure is important. Here's why. Because some people go, well, why do I care? Yes, it represents left ventricular stroke volume and all of those as well. But if you have a patient who has high blood pressure, okay, so let's say your patient has high blood pressure and it's consistently steady. It's not getting higher, not getting any lower, but let's say they're in the median range of high blood pressure. To say that it's really damaging, you have to look at the pulse pressure, okay? So again, Alfie, what did you say? Pulse pressure is the difference between what?
Systolic and diastolic pressure.
Right. So you take your systolic, take your diastolic, subtract the two, and then see if your pulse pressure is within a good range. So that lets you know that even though your patient who has high blood pressure, well, they're still within a safe range of cardiac function. So yes, you do have a lot of folks who walk around with high blood pressure, but if their pulse pressure is extremely wide, well, now you have a huge problem. Okay, so if you have a patient who has that pulse pressure still, diastolic and systolic are not that far apart, but if you've got one that is, now you have a patient who's in trouble. Okay, so it is definitely good to look at when you're talking about a patient and you're trying to determine if they're in trouble versus not in trouble. Okay, so looking at the pulse pressure, even for your own, good, is good. so pulse pressure, definitely something to make sure that you watch, and it represents left ventricular stroke volume. All right, let's go to the next one, 28.
Okay, what is MAP? What are the two formulas to calculate it? It is an average of pressures in the systemic circulation and thus the pressure best associated with the adequacy of tissue perfusion. And I have MAP equals half of the pulse pressure plus diastolic pressure. And then I have MAP equals systolic pressure plus the diastolic pressure times 2/3.
Yes, so you've got two formulas that you can use. Make sure you know the formula. So you can do 1/3 the pulse times pulse pressure plus your diastolic. That's one way to do it. You can do systolic plus, then in parentheses, 2 times your diastolic divided by 3. So figure out which one you want to do, because you will be asked to calculate your MAP. Okay, your mean arterial pressure. That's what that MAP stands for. All right. Okay. Get out a scratch sheet of paper if you don't already have one out. Let's go ahead and calculate MAP. All right. Okay. So if you have a blood pressure of 160/140, what is your MAP? 160/140. What is your MAP?
I got 200.
I got 146.
Is that right?
You got what? What'd you get, AJ?
146.6666.
Oh,
Yes, and you can round that 0.666 up. You can go to 0.7 or go to 147. So that would have been fine there too. AJ, tell us what you did.
Well, I took the systolic and I added the diastolic times 2, which is 140 plus 140 is 280. So 160 plus 280 is 440. And then you divide that by 3 and you get 146.6666, which is 147.
Correct.
okay.
Okay. Questions? All right, well, let's go on. That was 28, 29.
In detail, explain in relation to our vital organs why monitoring MAP is important. MAP is important to monitor in relation to our vital organs because circulation to the vital organs may be compromised when MAP falls below 60 millimeters of mercury. Elevated MAP is associated with increased risk of stroke and heart failure, CARC 336.
Okay, 60 millimeters of mercury, correct? Yes. All right.
All right, so number 30, our flashback question. Specifically, what is RQ and what does it represent? I said RQ equals the ratio of carbon dioxide produced to oxygen consumption, and it represents external respiration. And I found that in our pulmonary M&P PowerPoint from 210.
Yes, and what is the normal value for O2 consumption?
0.8.
And that's the normal value for RQ. So 0.8 is the normal value for RQ. So O2 consumption is a part of RQ. So what's the O2 consumption portion? What's that?
250 ml.
250, correct. 250. Because remember, your RQ is at 200 over 250. It works itself out to be 4/5. But the O2 consumption is on the bottom, so that's your 250 milliliters per minute of O2 consumption, or VO2, the acronym for that. All right, questions? All right, so at the top of your study guide, it said, in addition to these questions, review your previous notes regarding your vent modes, ventilation, ventilation monitoring, as well, because we're going to have questions for midterm as far as those as well. So let's look at entitle. Let's just go there. Entitle, since that's a part of ventilation and mechanical ventilation and advanced cardiopulmonary monitoring. So when we look at end-tidal monitoring, what's the difference between your end-tidal monitoring and arterial CO2? What's the difference between end-tidal CO2 and arterial CO2? Come on, what do you think? What do you think?
Didn't say we had that question before, wasn't it? Like
yes, you did.
percent is the last study guide, I think. Is it 5%? No.
It's not a percent because they're talking millimeters of mercury. So just
okay. Where's man? I just. Where's that? Where's that? Where's that? This that's oh gosh, no, I can't remember. I think it's. Where's it?
yeah.
1 to 5 less 1 to 5 milliliter 1 to 5 millimeters of mercury less than your PaCO2.
Correct. Yes. Tell everybody where you found that.
I found that on question 16 from study guide 3.
Okay. All right. So your end-tidal CO2. So what does that mean? That means when we're monitoring our patient, going to the ICU, we're looking at the monitor, and remember the monitor that I showed you that has the end-tidal CO2 on there. So when you look at the end-tidal CO2, you, in your mind, you're comparing that to the arterial CO2, but you're going to already know that it's going to be somewhat less than the arterial CO2.
Okay.
It's comparable. Yes, but it's 1 to 5 millimeters less. So if you drew a blood gas and you saw that those two were different, and they should be slightly different, your end-tidal should be less. Then of course they're not. It changes really breath to breath, but just to, if you were doing real-time comparisons, you would see that the end-tidal is slightly less. All right. Be good. Okay. All right. So, also talking about ventilation, we mentioned we had a lot of formulas. Airway resistance was one of those things, but here not talking about the formula itself, just what it is. So, what are some things that would increase airway resistance?
Pulmonary or airway edema, secretions. If they had like a tracheal tumor or something of that nature there, a wrong size ET tube.
Wrong size meaning too big?
Too small.
For the most part, right.
Think of the rest of it.
And high gas flow.
Yes.
I mentioned that as well. High gas flow. So suctioning, no. We said that suctioning would not increase the airway.
Right.
Not directly. If you continuously suction with on a mission and cause some issues to the airway, cause some inflammation, then yes, then you would cause some issues that way. But just suctioning as you should not increase the airway resistance. All righty. All right. What's the best measure of efficiency of gas exchange in the lungs? What's the best measure of efficiency of gas exchange in the lungs?
VD by VT ratio?
Yes. Very good. Yes. All right. And what's the normal range for it?
20 to 40%.
20 to 40.
Okay. Correct. All righty. What's the value that says a patient is not ready to wean when you're looking at VDVT?
Greater than 60?
60, right. 60% is what we're looking at. All right. Very nice. Very nice. All right. So going back to end tidal, what would be a reason why your end tidal CO2 would increase? What would be a reason why your end tidal CO2 would increase?
Wouldn't that be air traffic?
Explain.
If you're air trapping, you're not letting out that CO2, so it's going to be higher.
Right. So I want to know why would it be? Why would
If a patient has COPD.
If you have COPD, right? If you're chronic and your disease process is getting worse, that would be a reason. Yes. Okay. What else?
Decreased metaventilation,
Okay.
increased metabolic rates,
Yes.
and decreased ineffective ventilation.
Correct. Decreased effective ventilation.
Oh yeah.
Yes.
Sorry.
No problem. Correct. Tell everybody where you found those.
It was number 17 in the number 3 exam study guide. And I mean, specifically, it was page 1160 in Egan, box 516.
Okay.
But
If you want to get specific about it. Okay. All right. What are the two methods that are used to measure O2 consumption? How do you measure O2 consumption?
The Fick method.
Fick, yes. And
Analysis of inspired and expired gases.
correct. Very good. Correct. What's the normal value for your PF ratio? PF ratio.
400 to 500.
Right, yes. Greater than 400. Good value there. All righty. All right, and I know you guys know this. What's the single measure of effective ventilation? What's the single best method of effective ventilation?
SRPA
Arterial CO2. Yes. Not end-tidal CO2, but arterial CO2. Okay. What are some causes of error readings in pulse oximetry?
It could be the temperature of their body temperature, like if their hands are too cold. It could be nail polish. It could be acrylic fingernails. It could be movement.
Infrared light.
Patient movement. Yeah, a lot of bright light, UV lighting, or fluorescent lighting. Sorry. Trying to think.
Deeply pigmented skin.
Yeah. Anemia.
Somebody said motion.
Yeah, motion. I said motion.
Okay. All right. Yes, all of those. Would tachycardia be included in why that would give you an error?
No.
Okay, I heard that. Somebody said yes?
No.
Oh, okay. All right. So no. So the patient's respiratory rate and heart rate starts going up. That won't be the cause of an error. That would be the cause of a change, not an error. All right. Okay. If you have a patient who is on the vent, and let's go with NIV, non-invasive, not negative inspiratory ventilation, so non-invasive ventilation, and your patient complains of a lot of nasal congestion. Their nose is all stuffed up, and they have a lot of nasal dryness. Their nose starts bleeding. What do you recommend?
Heated humidifier.
HME.
All right, I heard a couple of things. I heard HME. I heard some other stuff.
Heated humidifier.
Heated humidifier. What's the other thing?
I said heated humidification.
Okay. Somebody say something else?
No. I think we
Okay. All right. Okay. So, yes, add a heated humidifier. Now, with NIV, you can't put an HME in line. So, you can only use that HME with mechanical ventilation. So, NIV, whenever you say NIV, think BiPAP or CPAP. Okay. So think BiPAP or CPAP. And then when you think of the circuit that you have with the BiPAP or CPAP, you can't put HME in line with non-invasive ventilation. So just remember HME reserved for that patient
mechanical
ventilation. Right, correct. Mm-hmm. Let's see. All right, so speaking of modes of ventilation, what mode would give your patient or would provide your patient with the least amount of worker breathing?
CMB.
The CMB.
Okay, CMB because
It's a full control mode.
Because full control mode and
they're sedated. They're out. They're not going to be breathing on their own.
Well, every breath is assisted.
Right. Every breath is assisted. The machine is doing all the work. There you go. The machine is doing all the work, so there's no work for the patient to do because the machine is doing all the work. Alrighty. All right. So, and more so, it's not assisted, it's controlled. So all of the breaths are controlled. So least amount of work there. All right. Okay. So on the flip side of that, which mode of ventilation would provide your patient with the most amount of worker breathing?
CPAP.
I hear CPAP with the echo.
Sorry.
No, it's okay. Y'all agree? CPAP?
I agree.
Not pressure support?
Ooh.
No, we'll stick with CPAP. Not pressure support.
You said greatest work of breathing for the patient?
Yes. Explain why pressure support would not be the correct answer.
Because do they trigger but don't cycle?
What does that mean?
They initiate the breath, but the machine still gives them some support. On CPAP, they have to do all the work.
Okay, yeah. Now pressure support, it does cycle, but with the pressure support, it does give your patient some added support. You get that, which is what it is. It gives the extra pressure on inspiration, so it does give extra support. Whereas with CPAP on inspiration, there is no extra support. Remember, CPAP is just like PEEP, which is end expiratory pressure. So there's that continuous pressure that stays in the lung. So there's no extra support to help get the breath in or start the breath or trigger the breath or anything like that with CPAP. It's all on the patient. The only support that CPAP provides is that extra pressure that remains in the lung when your patient exhales. So that's that PEEP or same thing that CPAP is. All right, so correct. CPAP would provide your patient with the most amount of work.
Yeah, I always just remember that by the fact that for a patient to have to be able to be on CPAP, they have to be spontaneously breathing. So to me, if they have to be spontaneously breathing, it's going to give them the less support. So that's how I keep it. It's like
no, be careful because pressure support you have to be spontaneously breathing too. That's why I asked. So they're both spontaneous modes, just like NIV with BiPAP. You have to be spontaneously breathing as well. But when you're looking at which one gives the least amount of support, you're talking about CPAP. Yeah, because all of those are spontaneously breathing modes, but CPAP provides the least amount of support.
Okay.
Yeah. Okay. Okay. All right. So talking about a patient who is on NIV. Okay. And for the most part, when you say NIV, they're talking BiPAP. But sometimes they will be talking about CPAP. So be careful. Look at your answers to see which one they're referring to. So if you have a patient a question that says you have a patient that's on NIV, look to see, well, what are the settings? Did they give me settings? Are they giving me an I and an E? So if they give you an I and an E, you know that it's BiPAP. Okay. So if it's just one setting pressure, then it's CPAP. All right, so for your patient who is on NIV, and here we're going to talk about CPAP, what would be the most adequate setting for a patient with cardiogenic pulmonary edema?
CPAP.
Cardiogenic pulmonary edema.
CPAP.
CPAP.
Yeah, it'd be the
I already mentioned CPAP, so what's the setting?
BiPAP. Oh,
I'm
setting?
asking for the setting. Yes. What would be the most appropriate setting for the patient with cardiogenic pulmonary edema?
8 to 12
The
centimeters.
8 to 12 on 100%.
Oh, there you go. There you go. CPAP of 8 to 12 on 100% O2. Correct. And where'd you guys find that?
Egan 1115.
Okay.
Also, question 28 on exam study guide number two.
Okay. All right. So if I gave you a group of patients, all right, a group of types of patients, and I gave you a list of obstructive diseases, and then I gave you a list of restrictive diseases, and I asked you to pick out the patients that had increased compliance, which group of patients would you pick?
The
obstructive.
The obstructive, right? So what diseases what diseases are included in the obstructive diseases list or group?
Bronchiectasis.
Bronchiectasis is one.
Asthma. He said bronchiectasis, bronchitis, and your yes, maybe that one.
What is it?
Cystic fibrosis?
Say it like you know, not like you're not sure. All of these obstructives should roll off your tongue very easily. Okay, so these are the majority of the patients you're going to work with. So these are your bread and butter people. Know who you're going to work with. So CBABES, and the best way to remember is just go down the CBABE and go down the acronym for what the CBABE stands for. So yes, your cystic fibrosis, you're talking bronchiectasis, your asthma, your bronchitis, emphysema. So just remember that. Also, you have some honorary members of that group. Who else would be included in that group? What other disease would be included in with the obstructives group? ARDS?
Isn't ARDS restrictive?
ARDS is restrictive, right? Now, keep in mind the obstructive group includes what kinds of patients, and this will help you with your answer. So what kind of patients, besides patients with high compliance, what other characteristics do they have?
Are you talking about like
COPDers? What characteristics does a COPDer have?
They retain CO2.
Thank you. That's the major issue there. They retain CO2. So who else retains CO2 besides the folks in CBABE? Drika, is it on the tip of your tongue?
Yeah.
Mallory, any thoughts? Let me help you out there. All right, so with your OSA patients, your OSAers, they eventually, and we're talking the chronic ones, they eventually belong into that chronic CO2. So they start obstructing after a while as well. So they will be in that group too. So with your OSAers, and remember the name is obstructive sleep apnea, right? So they belong in that group as well, because what happens to them at night when they're sleeping? They stop breathing, right? So they stop blowing off their CO2, so their CO2 just climbs and climbs and climbs, and over time, they become so chronic that they get switched to their secondary drive, just like the COPDers do. So they're in that group as well. So we need to make the acronym CBABE-O or something. I don't know. We have to change that acronym to add the obstructive sleep apnea. And there are actually some other diseases too that we could mention, but they're not as common as the CBABEs and then the OSAers. So just remember your OSAers, the chronic ones, we're talking chronic OSAers, because when you're not chronic, you're not retaining CO2 and then you're not obstructing. So you're not in that group just yet. But if you don't wear your CPAP at night, if you don't follow, the doctor's orders for changing your diet. If you don't, if you don't do what you're told to do and that sort of thing, then you're going to end up being in that group. So that would be something too to keep in mind when you have to talk to some of your patients, especially the ones who don't want to wear their CPAP at night, the ones who don't want to take their medication. They're constantly coming back to the hospital, and then you ask them, okay, so when did you last take your medicine? And they're saying, no, I didn't take my medicine. I don't take that medicine because I don't like the way it tastes, or I don't like the way it feels, or, for whatever reason they have, that would need to be addressed. Folks who can't afford their medication, that's different. But for the ones who have it, but just don't take it, is what we're talking about. For the ones who don't want to wear the mask because it's not sexy, it's not cute, so they don't want to wear it at night, type thing. Yeah, so there you go with that, and there's some who maybe they just haven't been educated on it too, so you're going to have to educate them on the machine. My brother-in-law, who he's lost a lot of weight, so he definitely has improved, but for years he battled with wearing his CPAP machine, and it just got to the point where I guess one of the doctors just flat out told him, you're gonna die. and he didn't like that, but still he didn't wear the CPAP. It was like, okay, so your doctor told you you're gonna die, but just we're out at dinner, and I don't know how we got on the subject, but he just said, well, do I really need to wear my CPAP machine? And I was like, yes. And I can go back. I can answer that one real quick. Keep on eating. Yes. Hello. And he said, because my doctor just told me that I was gonna die if I didn't wear it. Okay, well, I don't think you should not listen to your doctor. That is actually correct. And this man had asked me millions of times, should I wear my BiPAP? My CPAP? Does it really help? And it was like, okay, look, by now you already know, you just don't want to wear it. So, so you have folks who just don't want to wear it. And it is not the most comfortable thing to wear, so that could be an issue. So you should ask your patients too, why are they not wearing it? So maybe you can find a more comfortable mask for them, or a better fitting mask, something that will keep them, or wear it longer at least. If they could wear it 5 hours versus no hours, that would be great, and that would help them out too. So just remember that with your CPAP folks. It can be an issue. They do belong in that CBAID group because they do obstruct, and they can go to that secondary drive to breathe, which can shorten their lifespan, which you don't want. You want to avoid that. All right. Questions?
I'm sorry, when you're talking to them, can you encourage them and tell them that maybe it might be comfortable, uncomfortable, but try to find, to help try to find them a comfortable mask, and then tell them, to try to work their way up to where they need, or can you tell them that or no?
Can you tell them what?
Well, if they don't wear it at all and they can't stand something on their face, they can't, it's just uncomfortable. So they get a good size mask, but still they can't, it's so hard for them to get adjusted to wearing something. Would you encourage them to work their way up to sleeping with it all night?
I would. The first step is to try to get them used to the mask that they have. So if they try that and it doesn't work, then try a different mask. So it could be, if they say they don't want anything on their face, we'll try the nasal prongs, the prongs that don't sit on your face, the ones that go here, and then the mask comes above your head and goes back, so it's not on your face. So, you have different types of masks that might work better, that maybe the patient doesn't know about, or who knows, maybe their insurance won't cover it, don't know, but some patients are willing to purchase it. If you tell them, this is for your life, and the quality of life. So that's key too. So some patients, whereas my brother-in-law, he wasn't at the point where he was dying, but the doctor meant eventually, if you don't do what you need to do now, you're going to die sooner than you plan to. So that's part of it too. Your quality of life is going to get worse. So if you're a COPDer, that means when you're older, you will need oxygen. You're going to have exacerbations more frequently. That means more hospital visits. Who wants to be in a hospital, especially now during COVID? Plus your lungs are...
Odin, come here, boy. Odin.
So it shortens your lifespan, because remember, with obstructive anything, you start trapping air. Yeah. So when you start trapping air, that means the less air you can take in. So if you've got air in your lungs and you're trapping air, over time you get full. So that's how your COPDers die sooner than others, because at the end of their process, the main issue for them is that they can't take in any more air. So in order for you to breathe, you got to take a good deep breath in and then take a breath out. You got to exhale, but if you're already full, that means you can't take in any more air. You can't, you have no more gas exchange. You can't exhale because everything's in, you trapped all this air. So they have no choice, but to die. So that's the unfortunate part to that. And the quality of life is terrible, because what do we do for them? Well, we make them comfortable. We can put them on the vent, but there's so much a vent can do, and we make them comfortable. So that's very hard to live. If you can barely breathe, we've got you on a vent at 100% oxygen. We're trying everything we can, but all we can do is, palliative measures. We're going to terminally wean you, and that will be the end of you. So not saying it like that to your patients is, is important, but letting them know that's the
outcome of what will happen.
Yeah, that's the path that it's going to take. And a lot of times that lets them know, okay, and I better get used to this mess. And, so try to work with them. If you're in the hospital and, this is the patient who's been there, when you come back the next day, you have and he's still refusing, definitely, you can talk to them, and explain to them, this is, not be nasty. Definitely don't do that. Don't be, try to scare him straight, type thing, but to just say, hey, here is the deal. Here is and make sure they've been told that they have obstructive sleep apnea. So make sure they've been told that already. So if they haven't, then you can't say anything after that, but you can let them know that that's what it would lead to. But if they've been told, you can tell them straight out, you have a disease process that is progressive. So progressive means that it will get worse. So progressive means it will continue to take years off of your life, and it will continue to decrease the quality of your life. So you may not know it now, you may not feel it now, but when you get older, you will, and that's one of the arguments that I used to get all the time. Well, I've been smoking for 50 years, and I see it, and they still try to, emulate that cigarette in their mouth. I've been smoking for 50 years, and I feel fine. Okay, well, talk to me in 10 more years. Yeah, talk to me, and then of course, where are we? We're in the hospital. So, and I'm having to come in and give you a breathing treatment. So you're obviously not feeling fine, and they're in denial a lot of times about what fine is. So it's like, okay, well, number one, and then you have to go through the stages of how the disease process works, type thing. So in a lot of that, it is not repairable. You can't go back and now fix all of that, but you can start from where you are and slow down on the progression. So that's what you would tell them. You can slow down the progression of it by doing what you're supposed to do. Wear your BiPAP or your CPAP, take your medication, exercise like you're